Our group undertook the biomechanical evaluation of what is occurring at the hip or pelvis joint in both a healthy condition and a pathological condition, of which a right knee medial meniscus tear is occurring when cutting 90 degrees on turf, such as when a football player does this. Our phases of interest to analyze are initial contact to toe off. Our group consists of Dylan Papali, Tomas Springhetti, Paul Way, myself, Jacob Zerkle, and Jiaze Zhu. Occurring here is the full video of our 90-degree cutting motion of interest in a healthy athlete from a couple angles. We understand that members in our group may not have perfect form, but we're trying our best here to analyze what a proper form would look like. The big takeaway here is to notice how relatively symmetrical the body is staying when transitioning into, during, and after the cut. The trunk stays relatively tall in the sagittal plane, and the pelvis stays very level in the frontal plane. An important area to notice is that right hip. Notice how it stays stable and stacked in relation to the right knee and ankle joint. This will become important when looking at the right medial meniscus tear. Occurring here is a full video motion of what our group best postulates is what happens when an athlete with a right knee medial meniscus tear takes a 90-degree cut on turf. We will discuss assumptions in a bit, but for now, notice how the athlete takes an avoidance strategy to take the stress off the medial knee when making the cut. We assume this is best achieved by swinging the pelvis out to the right to place passive stress onto the outside hip and redistribute stress to the lateral side of the knee. Symmetries in the median sagittal plane and frontal plane are not achieved as fully as in the healthy condition. Some assumptions we have identified are listed here. As mentioned, we assume an athlete with a medial meniscus tear will use an avoidance strategy to avoid load on the medial knee, and so will place more load through the lateral hip and knee. We have also decided to analyze all four phases of movement at the portion where the right foot is connected to the ground and thus closed chained. We assume that thigh muscles are weak and that this athlete is in the acute phase of injury where compensations are the most extreme. To add to this, we assume the athlete has a right medial knee swelling and inflammation. Lastly, large compensations are taking place because this athlete is trying to increase performance of a skill and so is going 100% no matter the cost.
Phase 1 of this movement analysis will look at the initial point of contact of the right leg as it strikes the ground and when the foot is planted. We will take a look at the correct movement pattern in addition to the compensatory movement pattern with someone who has a right knee medial meniscus tear. Our main joint of interest here is the hip, and we will be looking at what happens at this joint when a patient is healthy and has non-painful symptoms in their right knee compared to if they are presenting with a right medial meniscal tear of the knee. So, taking a look at the frontal and side views of this initial movement, we have strictly sagittal plane motion occurring here. Looking at the joint movement of the right hip, there is slight anterior pelvic tilt just as the heel of the lead leg strikes the ground. In comparison, on the left side, there is a posterior pelvic tilt occurring here. On both the left and right sides, we have a concave on convex spin happening at the hip joint, where the acetabulum is spinning on the femoral head. Taking a look at the muscles acting on the hip joint. On the left leg, we have our hip extensors contracting concentrically, which includes our glute max and our hamstring muscles, whereas our hip flexors are contracting eccentrically. The muscles here include our rectus femoris and iliopsoas. Our stabilizers are our abductors, which include the TFL, or the tensor fascia lata, glute medius, and minimus. In relation, on the right side, our hip extensors are now contracting eccentrically, with our hip flexors contracting concentrically. The same muscles are activated just like on the left side, with exception of their actions, as they are opposite. Now, we are going to look at the compensatory movement pattern with someone diagnosed with a right knee medial meniscal tear during the initial contact/plant phase. The left and right sides will both still exhibit sagittal plane motion. However, the left side will now exhibit more transverse plane movement compared to with the right, which will display both transverse and frontal plane motion. Pelvic posterior tilt is still present on the left, just like the normal movement pattern, except there will be slight external rotation at the hip. Anterior pelvic tilt will also be present on the right side with the addition of adduction and hip internal rotation. We still have a concave on convex spin on the left, but now there is an anterior roll and glide happening. The right side now is drastically different as we have the addition of a posterior roll and glide and inferior roll and glide. One important distinction I want to make here is that where we had a neutral heel strike during the normal movement pattern, we now have a lateral heel strike during the incorrect movement pattern. This compensation is crucial to point out as someone with a right medial meniscus tear will want to put less stress and load on the medial aspect of the knee, as they know it can cause increased pain. It's also important to note that the weight distribution is on the lateral aspect of the foot/leg compared to with the normal movement pattern, the weight was more evenly distributed. Finally, looking at the muscle forces acting on the hip, on the left side, the hip extensors are contracting concentrically, but mainly it's the biceps femoris that's being activated here. The hip flexors are contracting eccentrically with our abductors acting as our main stabilizers. The same muscles are involved as before. On the right side, the hip extensors are contracting eccentrically, but with a focus more on the semitendinosus and semimembranosus. The hip flexors are contracting concentrically just like before, but with the addition of our hip internal rotators. The muscles here include our glute medius and minimus. We also have concentric contraction of our hip adductors, such as the adductor longus and magnus. In conclusion, those are some of the differences noticed during this compensation. And now we take a look at phase 2.
Alright, so we'll be calling phase 2 the loading phase. And this is characterized by our athlete loading up on that right leg, preparing to pivot 90 degrees to complete the cut. So at this point in time, he has not yet started the turn. This phase will be taking place immediately before that. As we can see in our healthy individual, the motion is strictly in the sagittal plane still. We've got some healthy right knee flexion, as well as the right pelvis tilting anteriorly, as the hip extensors, so this would be primarily the gluteus maximus and hamstrings, they're going to be loading up eccentrically. At the same time, we have our hip flexors, so this would be mainly the rectus femoris and iliopsoas, they'll be working concentrically. The point of increasing these angles of flexion is to lower the center of mass and allow the athlete to start to make his turn. The big difference from phase 1 here is that we have a sizable increase in muscle activation. There's an increased load on our hip flexors and extensors, and this directly corresponds with an increased anterior pelvic tilt on the right side. The joint arthrokinematics are the exact same here as they were in the previous phase. So on the right hip, we have the acetabulum spinning on a fixed humeral head, and on the left hip, we have the acetabulum spinning in the opposite direction, also on the fixed humerus. So the big takeaway here is that the motion is still strictly in the sagittal plane, and there are no obvious restrictions in loading of the hip and knee. Now let's contrast that with an individual who has a right medial meniscus tear. If we go ahead and look on that picture on the right, we can see that the motion is no longer strictly in the sagittal plane. We have now introduced motion in the transverse and frontal planes. Starting with the transverse plane, the right hip is internally rotated to allow for more weight distribution to be placed on the lateral aspect of the lower limb. So this is going to be a concentric contraction of the gluteus medius and minimus. This in turn will fire up the hip adductors on the right side as a compensation. So this would primarily be the adductor longus and magnus. Another difference in this scenario is that there will be more activation of the semitendinosus and semimembranosus on the right side, and this directly corresponds with more activation of the biceps femoris on the left side. If we go back to that picture, we can clearly see that the right hip is sticking out to the side laterally, as the individual is attempting to compensate for a lack of medial knee stability. Now, if we go ahead and switch to the picture on the left, we can see that the individual has less knee flexion. This could be possibly due to his desire to avoid putting unnecessary strain on that right knee. This directly leads to the right hip taking on more of the load, and that will increase the amount of anterior tilt and forward torso lean. As for the arthrokinematics, these new joint motions will also introduce new joint interactions. So on that right side, we will still have that acetabulum spinning on the humeral head. However, there will also be a posterior roll and glide as well as an inferior roll and glide as a result of adduction and internal rotation being introduced. On that left side, we will have increased external rotation, and this will give us an anterior roll and glide as the acetabulum moves on the femoral head. The big takeaway here is how small differences in how the knee behaves will cause a domino effect, and this will impact the joints above and below.
The third phase of the movement is pivot and shift. In this phase, the athlete will turn direction 90 degrees to the left and shift body weight from right leg to left leg. In this phase, left hip is performing motion in transverse plane. The right hip is performing motion in frontal and transverse plane. Since the left leg is turning to the new direction, the left hip has to perform external rotation to make the turn possible. The motion is in open chain because the distal end of the extremity is not on the ground. The femoral head is rolling posterior and gliding anterior on the acetabulum. Left hip flexor rectus femoris and iliopsoas are concentrically contracting. Hip extensor are also firing to stabilize the hip. Gluteus maximus and hamstrings are eccentrically contracting. Hip abductor, gluteus medius, minimus, and TFL are concentrically contracting to control the pelvis level. The hip external rotators are concentrically firing to turn the hip externally. Since the right leg is planted on the ground, turning the body to the left will cause external rotation and abduction of the right hip. Both motions are close chain. For external rotation, the acetabulum is rolling and gliding anteriorly on the femoral head. For abduction, the acetabulum is rolling and gliding superiorly on the femoral head. For the right hip, flexors, rectus femoris and iliopsoas are eccentrically firing. Hip extensors are firing to stabilize the hip. Gluteus maximus, hamstring are eccentrically contracting. The hip external rotators are concentrically contracting to turn the hip. Hip abductor, gluteus medius, minimus, and TFL are concentrically firing to abduct the hip. Hip adductor longus and magnus are also contracting to stabilize the hip. When the right medial meniscus is teared, the athlete will compensate to avoid pain. Left hip would move in the transverse plane, and the right hip would move in frontal and transverse plane. The motion of left hip is external rotation, which is in the transverse plane. The motion is open chain, so the femoral head is rolling posteriorly and gliding anteriorly on the acetabulum. The left hip flexors are concentrically contracting, and the extensors are eccentrically firing to stabilize the hip. The left hip external rotators are concentrically contracting to turn the hip externally. Also, the left hip abductors are concentrically firing to level the pelvis. The right hip is performing external rotations in the transverse plane and adduction in the frontal plane. The adduction of the hip can decrease the compression on the medial meniscus. These motions are in close chain. For external rotation, acetabulum is rolling and gliding anteriorly on the femoral head. For adduction, the acetabulum is rolling and gliding inferiorly on the femoral head. The hip flexors will contract eccentrically, and the hip extensors will contract concentrically, same as in a healthy condition. The hip abductor, gluteus medius, gluteus minimus, and TFL will contract to stabilize the hip, but the stabilization may be weak. Hip adductors, adductor longus, adductor magnus, are working concentrically to bring the femur toward the center line. Hip external rotators will contract concentrically to external rotate the hip.
For stage 4, the takeoff stage, under the healthy condition, the motion on both sides of the hip is regarding the sagittal plane. As seen in the picture, the pelvis is level, and this is indicative of motion in the sagittal plane. For joint movement and osteokinematics, on the left side of the hip, the pelvis tilts anteriorly, and the pelvis moves on the femur. The orthokinematics is the acetabulum spins on the femoral head. During this motion, the hip flexors are concentrically contracted, while hip extensors are contracted eccentrically. On the right side, the pelvis tilts posteriorly, the pelvis moves on the femur, and the acetabulum spins on the femoral head as the same as the left side. Here we have the hip extensors, like glute max, all 3 hamstring muscles, contracted concentrically, while hip flexor contract eccentrically. In the meantime, hip abductor contract concentrically as well for maintain the pelvic level. With the right meniscal scar, the left hip is the same as the healthy condition, moving in the sagittal plane. However, as we can see from the picture, the pelvis is not level at this point, so the right side moves in sagittal, frontal, and transverse planes. For the left side, everything else is the same as the healthy condition. As for joint movement, the right side posteriorly tilts. However, the right hip also does slightly abduction and internal rotation as compensation. The hip moves on the femur. Besides the acetabulum spins on the femoral head, there are also acetabulum superiorly roll and glide on the femoral head for abduction and posteriorly roll and glide on the femoral head for internal rotation. Hip extensors, hip rotators, and hip abductors contract concentrically while hip flexor contract eccentrically.